All right, we've hit noon, so I think that means we can go ahead and get started. Um, so grateful for all of you being willing to join us today. We're really excited about this series, really excited about the opportunity we have to talk a little bit about health equity in the state of Utah, especially in rural Utah. A little bit of background, this series is being put on by the Rural Health Association of Utah. I'm an employee of the Rural Health Association of Utah. I'm a program coordinator. And I'm just really excited about this series. I think it's going to be interesting. I think it's going to be a lot of fun. We hope for a lot of participation from you as well. So we'll go ahead and jump into it. So if you're not familiar with what Project ECHO is, it's collaborative virtual education. Doesn't seem all that groundbreaking now because we're used to, 2 or 3 years of Zoom meetings, team meetings, sort of the electronic side of work that we've been living in the last few years. But at the time, it was really innovative. It was created at the University of New Mexico, and its primary goal was to provide health education to rural and underserved providers. It is now expanded to go beyond that. There's lots of different functions of ECHO, but that was its main purpose and sort of the main purpose for this, although we have lots of people from diverse backgrounds here today, and we're going to get to that in a minute because you'll have a chance to introduce yourselves. But because we're focused on health equity, we want you to feel like you are in a comfortable place to bring cases to discuss. Obviously, we want to be careful not to disclose protected information, but we want to make sure that you feel comfortable collaborating here because we do have people in this session that are experts in their fields, and we've got a lot of different backgrounds and perspectives. So we want you to feel comfortable if you have a case that you're currently dealing with or previously dealing with that helps add to the discussion. We want you to feel like you can go ahead and bring those to the table and we can talk about those. When you comment, and this goes for, ask a question or, we're having a discussion, just at the beginning, remind us your name and your organization, just so we can get an idea of what your day-to-day experience looks like especially with equity. Because all of you are coming from different perspectives and different backgrounds, and that does obviously form your background and your experience. And so we want to be reminded of that. That just helps us, and it helps us get to know each other. We want this to be a collaboration where we're able to work together and able to build a network here of people that we can come to if we have problems, issues, questions, different cases. So a few just kind of ground rules for the session, for the series. We're here to help each other. We don't want you to hesitate to speak up. So a lot of this is just going to be moderated. We will have speakers in the upcoming sessions that are in the field and dealing with the issues on the ground, but we want you to feel like you are equally able to contribute. So don't hesitate to speak up. We want the discussion. It's not just a lecture series where there's one speaker and that's it. You just sit and listen. We want the discussion and we want to cultivate solutions. We do want everyone to have a chance to speak if they feel so inclined, but we don't want you to feel pressured to speak if you don't have anything to say. We know some will have more to say than others, and we know certain topics will, people are passionate about different topics and different things. So we don't want you to feel like you have to talk. This isn't like a second grade classroom where we're going to call your name out of nowhere. But we do want you to feel encouraged to speak and to be able to ask questions and give comments. And then we just ask that you keep it civil. We know that equity is something that we're passionate about, and we know there are areas of equity that people are more passionate about than others. So we understand that there's passion and there's, obviously a lot of passion behind what we're doing, and we know that that's something that we're all dealing with every day. So passionate discussion is great. And we welcome that, but we don't want arguments here. This isn't Fight Club. So we want to welcome the discussion. We want you to feel comfortable bringing viewpoints to the table, even if they're differing viewpoints. And we welcome that discussion, but we don't want to knock down, drag out, yelling at each other. This is not the format for that. So really quickly, this little QR code is the same one. If you filled out the form to register for the series, it's the same as that. So you don't need to do it again. But if you got the link to this Zoom from a coworker or from a friend, from someone in your network, and didn't fill out the registration, we just ask that you do that quickly. That'll give us an idea of where you're coming from, where you're practicing, what your background is, and also it'll give you a chance to list some topics that you're passionate about. We do have most of the series lined out at this point, but we do have some flexibility in the content that we can bring to the table, and we want you to feel like you're getting the most out of this. There are quite a lot of you here. Typically in the ECHO model, we take the time to go around and introduce each other. But because there are so many of you, why don't we just have you drop your name and your organization in the chat? And if you want to put where you're located, then that's fine as well. We'll take a minute to do that, and that gives you a chance to fill out the survey as well.
We'd actually encourage you to drop your location as well, so that we can kind of understand if you're able to make comments today, kind of what area you're representing.
Okay, so that was not what I meant to do. Yeah, it looks like we've got, I know we've got a lot of people from DHHS, which is great. RISE program, Tricolor Health, psychiatric nurse practitioner. Oh, Megan, that's awesome. Uinta Basin. Dove Center. Yeah, we've got, like I said, we've got people. I was looking through this morning just to see. Obviously, I've been looking through beyond this morning, but just wanted to get an idea of all the different backgrounds that we would be seeing today. And I was really excited when I saw just how many people signed up and all the different backgrounds that they're coming from, because that's really going to add to the discussion and really going to be something that is useful for us. So this is really awesome. Really cool to see all of the different things that we're doing, and cool that we can come together with a common goal of working towards health equity, and especially in this state that we work in and love and care about, people that we care about in our communities. Just awesome. We've got people from all over. It's very cool. So I just wanted to start off with a little bit of background on this series, kind of how it came about, how we got to this point. Want to give a shout out to our funder. So the projects this project, and we are working on other projects as well. Those have been supported by funds made available from the Centers for Controlled Disease and Prevention in the U.S. Department of Health and Human Services, in an effort to address inequities made more evident during the COVID-19 pandemic. So the Utah Department of Health and Human Services and the Office of Health Equity within that department have partnered with us and the Office of Primary Care and Rural Health to address some of these inequities in rural Utah. Our office, my office, the office that I work for, the Utah Center for Rural Health Association of Utah and Southern Utah Area Health Education Center. You can tell we have a little bit of an identity crisis. We have a lot of names for our office, but we do a lot of different things as well. We were tasked with creating a comprehensive database of all health resources in rural and frontier Utah, and this Project Echo series on health equity. And I just wanted to mention, because we have had some questions about it, we have partnered with this database that we've created, which can be found on RHAU.org, the Rural Health Association of Utah website. We've partnered with Utah 211 to make sure that we have all of the resources available to everyone in the state. So yeah, we've had some questions about whether this was a competing database or whether this was encroaching on their territory. We just wanted to make sure we had a comprehensive database. There are things that they cannot put in their database that we can put in ours and vice versa. So we just wanted to make sure it was comprehensive. We work closely with them. We have a link to Utah 211 on the database page. And we are really grateful for that partnership because we know that we working together on that is giving Utah and rural Utah the very best to find all of their options for resources. So just to start out this series, it's a 6-part series. We can kind of come back to this. We wanted to line out what equity means. And really, in a word, equity is fairness. We know that life is naturally not fair. That's just the way the cookie crumbles. Life is not fair, but we can make things equitable and try to level the playing field. I saw my mom sent me a little Facebook meme, and I sometimes they're funny, sometimes they're more serious, but it was the difference between equality and equity and just natural life. And so it was, there was a baseball game going on and kids behind the fence, and there was just regular life and the kid was staring directly at the fence. And then there was equality, which showed 2 boxes the same height, but one really tall girl and one really short girl. And so obviously the really short girl still couldn't see over the fence, even though things were equal. And then it showed equity, which had boxes of different sizes that the kids could stand on. And so that, I think, is a really good visualization of what we're looking for with equity. From the CDC, their definition is that health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. Achieving this requires ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and healthcare, and eliminate preventable health disparities. And so this sort of gives us an idea that we can come back to when we're talking about equity and health equity. Throughout this series, we can come back to this and remind ourselves of the goal. And so for the rest of this session, we want to, oh, thanks, Sarah. Keep an eye on the chat. Yeah, that really is a good, I have come back to that again and again, that visualization. It just is a really good reminder of the differences. And we know equality and equity are both important. They're also different, even though they're so similar. There is that difference, and it is important. And so the rest of this session, we want to hear from you because we can kind of shape the rest of the series around what we have already heard, the feedback we've already been given, and the feedback that we hear from you today. So we want to open up the floor to some questions. I've got a few questions here. It's okay if we don't get through all of them, but I want to make sure that we are providing you with the very best series possible, because we've only got 6 parts. We could have an echo session every day this year, 365 days, and not cover every single topic that falls under health equity. So we know that 6 sessions is pretty limiting for a series. So we want to make sure that the 5 sessions that follow this one are all tailored to the things that you're seeing, the things that you're dealing with, the problems that you may see coming down the road. And so to start off, the first question really is just, what are you seeing in your communities, in your practices, in your departments? What are you seeing on a daily basis?
And we are monitoring the chat box as well. So if you're not super comfortable with speaking out loud, you can go ahead and put it in the chat box.
Yeah, yep, we'll
Uh,
monitor the chat. Looks like Caitlin Webb, a lot of hesitance to use programs we offer. Yeah, for sure. We definitely see that. And Caitlin, remind me, I'm scrolling through the chat if I get there before. You're with the, yeah, with the RHAU programs with DHHS. So yeah, I'm sure you see all the time there, you know, the program is great and people could get a lot of benefit about it if they weren't so hesitant to use it. Or if they know about it. I know that's a big issue too, is a lot of the programs are in place, they're just not marketed or advertised.
Caitlin, have you seen reasons why, and this is some of the stuff we want to uncover today, but reasons why people aren't using the programs? What are the barriers? Is it lack of knowledge?
I think there's quite a few different barriers. I think one is mistrust of government programs or any other type of programs, mistrust of what the records will do. There was a lot, especially in regards to COVID, a lot of misinformation that was passed through. And so a lot of those barriers is lack of knowledge of where to get correct knowledge. And so I think that has really made our jobs a little bit more difficult, because not only in doubting the reality of COVID-19, I think that bled into other areas of them being like, okay, well, what else could be a lie to us? And so there's just a lot of mistrust and hesitance to even have a conversation.
Yeah, I guess, and I think this will tie in later, but yeah, building that trust, rebuilding that trust, because I think obviously there's always been some level of distrust, but rebuilding that trust that was there, at least to some extent, and building it even further, that's going to be a huge part of bridging the gaps. Couple more things in the chat here. We had Kylie Peterson from Intermountain, large inequities between rural and urban areas for cancer screenings, specifically mammograms and colonoscopies. That's a huge one. And, you know, cancer screenings in particular, but lots of specialties. There's a huge disparity between the access you have in a rural area and an urban area. And that is interesting, because there is, with the advances in technology, obviously we can use some resources to continue to bridge those gaps and, you know, do virtual visits, telehealth. But for screenings, cancer screenings, that is such a tough thing to bridge, because there is such an inequity there. Brittany Brown had a couple challenges to understand community needs and increase awareness, and then challenges to reaching populations with barriers to accessing healthcare. Those will both be huge topics of discussion that we'll need to have going forward. To just, how do we bring awareness to these things, and how do we make it comprehensive enough that people really feel like they understand what they're getting when they start using these resources. I know that is a challenge personally that we've had as we've made the rural health database. It's, you know, how do you bridge the gap between having, you know, this much space on a website to be able to describe something, and making sure that it's thorough enough that they understand exactly what the goal of the resource is. So huge challenges, definitely something we're going to want to keep on the forefront of our discussions going forward. Anything else that you guys are seeing that you would like to discuss before we move on to the next question? I'm going to go ahead and move to the next one then. Where are you seeing success? Because and maybe this is just me. I think we tend, when we talk about these discussions, we focus on the problems so much that we forget that there are success stories and there are positive aspects of health equity. So maybe that's just my mindset. Maybe that's a me problem, not an everyone problem. But I want to make sure we're highlighting the success and the good things. Does anyone want to share maybe a success story or just a program that they've seen that has helped bridge health equity? And again, this is chat or unmute, so whatever you're most comfortable with.
Can you guys hear me?
Yeah. Yep.
Hi. Yeah, my name is Carlos. Yeah, from Holy Cross Ministries. I think and I'm kind of new in the position. I've been here for a few months. And one of the things that I've seen in the past couple of months and something that we want to do heavily here at Holy Cross Ministries this year is to be at table in events, doing the community outreach work, out there in the community. That seems to be, I don't know, we're able to reach the community, in real time and make that connection and make those appointments for whatever they might need. So we've seen success when we're out there doing the work in the neighborhoods.
Oh, that's great. That's great. What how are you finding those events? Are you finding them just on community pages?
Well, like, for example, right now I'm messaging a couple of you guys just to get email addresses and then just make those introductions and, say something along the lines of, if you got something, let me know and I'll do the same. So it's been a lot of just getting emails from the websites and just reaching out to different places and inviting them to the office here and talk about, or we can go over there and talk about the services that we both offer and see if there's room for collaborating.
Oh, that's awesome. Yeah. Yeah, that's another huge benefit of these types of series is the networking that we're able to do. We're able to work together. We're all working together for that common goal of bettering our communities, our healthcare, all of these things. So that's great. And an awesome idea just to, get out there in the community and show who we are and let people know all of the things that we are able to offer. Any other success stories that we want to share before we?
The one I have, this is Kenneth Applegate. I'm just going to use past experience from a previous job. Is it public health? There's a lot of things that share similarities. It was corporate wellness, but there were still inequalities and inequities we would still find within that environment, because you would have a corporate wellness program and it's still about trying to reach all the people, because not everyone would be involved. Not everyone would want to be involved. There's a lot of cultural, there were a lot of cultural barriers and people wouldn't want to do anything, have anything to do with it. And there were still trust issues. But in those situations, we would always have find out who they trusted within their particular group. So, for example, maybe in one company, maybe it was largely Vietnamese. We would find those people that the group, the majority of the group, looked up to for guidance. Maybe there was a language barrier, maybe there was a cultural barrier, whatever it was. There was still only one or two people they would look to for guidance, and it was about getting with those people and making sure that there was a relationship there, understanding that this was for the good of everybody. Or maybe there was another company where it was mostly Tongan or mostly Filipino, whatever it was. is being able to understand those barriers that were there and trying again to build that relationship and make sure that there was an understanding. And sometimes that takes digging into the culture, and sometimes that takes understanding where people are coming from. And so that's been something that's been successful in making sure to understand, okay, who are we talking to, and how can we better understand what they're living and how they're experiencing.
Yeah, that's great. Just a great example of what can happen when I think breaking down barriers is such a huge part of what we do, and where we see success in what we're doing is breaking down barriers. I'll give if anyone else wants, I'll pause for a minute if anyone else wants to share, but
my name is Michelle Fowler. I'm with Tri-County Health in the Uinta Basin. And I know that some of our successes have came from collaborating with organizations that is in our area. So Northeastern Counseling, the Uinta Basin Government Association that runs the food pantries. We have reached out to them and actually got on to associations that they have, just so that we can build that trust. We've also reached out to the Ute tribe that is on with us. There's been a lot of trust issues in the past, and we have been trying to break those barriers down, and we have actually been successful this last year with collaborating with them, doing different events and helping them out. And we're starting to see a big turnaround in just the help that is being given to all of the organizations that have been able to come together and work together.
yeah, that's great. Yeah, collaboration's the name of the game. You know, we all bring different things to the table, different things from our different organizations, different strengths, personal strengths. And so, yeah, collaboration, that's huge. Maybe a few more seconds here. If anyone wants to share successes, but if not, we can move to the next one. Okay, we'll go ahead and move to the next question. What are the barriers that you're running into? Common barriers, or maybe uncommon, but what are the barriers that you're seeing?
You mean besides money?
Money is certainly a huge barrier in a lot of areas.
Yeah, money and insurance, subsidized health, all of the things that play into money. It's a huge barrier.
Well, what I mean is it's not actually directly money, but it's having the budgets for, to get the resources needed, especially when it comes to mental health. We all know that the mental health need is huge out there. We need consistently short resources. And sometimes that's money. This is Robert Lee Community Health Centers. As part of addressing some of the language barriers that we're talking about just a minute ago, some of it's just finding people who are bilingual. Social workers. We require our social workers to be bilingual so we can address some of those cultural and language barriers that our patients experience. Those qualifications don't necessarily run around in abundance.
Yeah, there were quite a few there that were touched on. Money, access, the workforce is a huge one that we're seeing right now, a huge barrier.
I'll just piggyback off of what Robert's saying. I'm Casey Shakespeare. I'm with Austin, and just sharing some experiences from some of our community partners who are not here with us today. I won't name the clinic out of respect to the clinic, but I work with a clinic in rural Utah who has a mental health professional position open. They received the funding for it, so they got through that barrier, but they are going on nearly 2 years of trying to recruit a professional to come to their small rural Utah community to take that position. And they have been unable over 2 years to find somebody to fill that position. And not only have they not been able to fill that position, but they lost the other mental health worker that they had. So now their mental health department is basically on hold, and they've been struggling to find anybody who was willing to move to their community to fill those positions. And I'd invite anybody else who's seen similar type situations if you want to chime in as well. Trudy says the Dove Center is experiencing the same type of positions, and you're in St. George, correct, Trudy?
Yeah, that's correct. We're right in St. George, and we had, before the pandemic hit, we had, I want to say, I wasn't with the organization at the time, but I want to say we had at least four full-time counseling positions. And right now we are running on 3 part-time positions. We have one opening for a full-time counselor that we just haven't even received resumes for. So we also have funding for that position and need it desperately, but we just have a hard time bringing people here.
And St. George is the biggest of rural communities in Utah. So if you guys are struggling to find workforce in St. George, it just goes to show how dire the situation is for some of these small rural communities.
Yeah, this is Robert again. One of the things that we're thinking about on how to address that was a little earlier in we've got a grant application that we haven't looked at, but it's for maternal care for rural and underserved populations. But part of that, if we do get the grant, it will actually be for funding the training program for advanced care practitioners, APCs, training them in rural care. And what our thinking is that if you train providers in an environment where you train providers in an environment where you would like them to continue their practice.
Mm-hmm.
And that way it's not, you're not trying to grab someone that has never had any rural health experience. And they would be reluctant to practice in those areas. And so our idea was to take a step, one step back and train professionals in those environments with the hopeful outcome that they will stay in those communities and help grow healthcare in the rural communities. So that was our.
So you know the due date.
Let's see, Liz, I see that you raised your hand.
So I had a rural health clinic in Colville reach out to me about a patient who needed a sign language interpreter. The patient was 17. She had permission from her mother to have autonomy for the appointment. So we looked at a lot of options. They ended up having it was cheaper to have somebody drive there and do the actual interpretation than it was to do one of the Zoom availabilities. And obviously they want to offer that service, but they took a loss on the appointment, on the money. So the barriers are more than just language and skin color and sexual orientation. There's different ability barriers as well. And when you are in a remote area, it's a lot harder.
Yeah, for sure. And especially, yeah, just there's so much more that goes into it than the
Right.
surface level things that we think
So
of.
when we think of equity, we often, and diversity, equity, inclusion, we often think of nationality, heritage, ethnic background, skin color, sexual orientation, but it's so much more when you're in a wheelchair or you use a cane to see or you use hearing aids. And I wear hearing aids, so I'm just super aware of that. It's a struggle. And during the pandemic, even in urban areas, talking through plastic doesn't work for me. I struggle really hard. And I'm not even profoundly hearing impaired. So it's just really interesting. And telehealth is weird too, because I need to see all the nonverbal language. I lose something when I don't see people in real time. It's crazy.
Yeah, no, and it's again, this is why it's so nice that we're able to collaborate like this, because that's something I wouldn't have even thought of is sign language, needing an interpreter. So great things. And I can confirm that we are going to have a session on disability equity at some point in the series. So that is something we will definitely be touching on. Any other barriers that we're
I
dealing with?
want to voice one more that came up during, we spoke a little bit about this topic at our Rural Health Association Utah conference last month, and Tatiana Bailey with the Utah AHEC, housed at the University of Utah, made a comment that I want to share with the group because I'm interested to see if anybody else has any thoughts about this. But she made the comment for some of the Hispanic population that one of the barriers that they experience is when they look at a resource, if they're not sure what the requirements are to take advantage of that resource, many times they won't even attempt to take advantage of that resource because they're worried they won't qualify, whether it be their visa status, that kind of thing. And I'm curious to see if maybe that's a barrier that some of you have observed, that some of these populations, if they're unaware of the requirements, won't even try to take advantage of them, or if you see anything similar to that. It's actually something we are going to try to address on our database by trying to work towards adding some of the requirements to engage in those resources on as many as we can.
There from Intermountain Healthcare. I'm here with Kylie in the room. We absolutely experience that as well in a couple different ways. As we support individuals who may not be documented and feel safe, right? There's a lot of fear, and that could be from signing up for insurance to coming into the hospital or the clinic to get care, and it trickles down to their kiddos as well, right? Which many times we just want to support and help, everyone, but when we think about the kiddos and the care that they need and how easy it is to get them insurance, we know that our state, supports kiddos, undocumented or not. And so it's really, we have to think about that as well as we set up our processes and how we support all of our communities, and really thinking about from our marketing campaigns to the conversations that we're having, whether it's at events or just as providers and as employees with our individuals who may have some fear, whether a refugee or undocumented. I don't know, Kylie, if you had anything else to add there.
No, that's great. And it's not enough to just provide, materials and education in different language. We do need to figure out a way to go a step further to make these communities feel comfortable accessing our resources. And just like you said, Austin, there is that discrepancy in utilizing those resources because they don't know if they're applicable or if it will get them in trouble.
Yeah, and it looks like that's something that we're seeing as well in some other organizations. I know we've got WIC mentioned in the chat. Sounds like people are afraid to use these resources for fear of not, for all of the fear, all the variety of fear that comes with whether it's insurance or documentation, all of those things.
Yeah, not to mention that a lot of them don't have like whatever documents needed for that whole process, you know. Like here at Holy Cross Ministries lately, we've been seeing a lot of like recent arrivals into the States, you know, so a lot of these people, they're here literally, they just enter without a place to stay or whatever, and try to find them like an apartment or something like that. It's almost impossible because they don't have, you know, any sort of bill or anything under their name. And so, and not to mention that, especially coming from, I don't know, South America or Mexico, like in my instance, like you don't know about nonprofits, you know, over there. So you come into the States and where the nonprofit organization, it's pretty well established, you know, and the goal is to help the community. But we come here and it's like, first, you don't know. And then second, you know, you're already kind of wary of oh, is this part of the government, you know, because you can't really tell the distinction between one or the other, you know. I know that for me, I mean, it sounds kind of dumb because I work on a nonprofit now, but for the longest time, I didn't even know about nonprofits until I started working here, you know. And so I know that just the community being aware that we exist, I know that's a thing for me. That's kind of a barrier for us too.
Carlos, a follow-up question. So I spent some time in South America, and I know I'd worked with some folks that were trying to get a hold of like their birth certificates and things like that. Even when they're still in some of those countries, my understanding is they have a difficulty accessing those papers. But let's say somebody immigrates to the US from, for instance, Peru. My understanding from being, that's where I spent my time, was in Peru. They had to travel back to the province they were born in order to get that birth certificate. Is there any way for some of these folks to get a birth certificate or some of those papers from their mother country without physically going back to that province where those records are held?
Oh man, I don't, to be honest with you, I don't know. I would think so because I know that, I mean, Mexico is kind of a different thing because, you know, we're just kind of right next door and there's Mexican consulates all over the place. So if you need a Mexican birth certificate, you just go and you just get it. But for countries that are farther away, I would imagine that the first step for me would be to go to that consulate and just ask them, you know, what's needed to get whatever document that person needs. That's what I would do.
So thank you.
Yeah. Thanks, Carlos. Liz, you got your hand up.
So Carlos can correct me if I have this wrong, because depending on what's happening in the asylum process, when I worked in Indiana in a role similar to Carlos's, we were able to use asylum paperwork because they would put the date of birth. But every state is different, and that's what's so confusing for people who migrate here, because the laws are different everywhere. You know, in some states, you can get full Medicaid as soon as you hit the shore, if you have the appropriate documents. In some states, you wait 5 years. You know, and I'm watching Indiana because they're talking about providing Medicaid for children and women right away, and not making them wait. And that would set a great precedent for Utah. But sometimes we could use asylum paperwork, and if this was applying for Medicaid or Marketplace, sometimes we could get into the Marketplace insurance. If you are a victim of human trafficking, we automatically had an option to get them into Marketplace insurance because they had paperwork from our government getting them here. But of course, things at the border are tricky. Regardless of whether you agree with how it's being done or not, it's tricky. So Carlos might have more to add to that, but it's tricky. It's a hot mess.
Yeah, I agree. It's tricky, and then it's just, yeah, well, we just try to do our best to help all this, everybody really, you know, whether they're Hispanic or English speaking, just whoever. But we've been seeing a lot of asylum seekers or who come into the agency, and we try to get them enrolled into Medicaid, you know, because, you know, even though you still need medical coverage if you get pregnant or whatever. But on top of finding them housing and all that, a big problem that we're seeing is that a lot of them continue to be victims of some sort of crime, whether it's domestic violence or you know, robberies or whatever it might be, you know. So it's like their problems don't end once they enter the States, you know, but we just try. And I think that's why collaborating, because we're talking about how resources are limited, you know, and hiring people, finding people for positions, it's really hard nowadays. I know we also have been having this problem, but I think that's why collaborating together as different agencies it's crucial, you know, because whatever we can't offer here, if we know a place that offers that resource, then it's a win, you know, for all of us and for the client.
Yeah. Liz, yeah, go ahead.
And that is a great point to bring up, because I find that people who immigrate here have PTSD. And they have been through things we can't even fathom. What they're escaping from, how they got here, what they went through to get here. No wonder they're afraid. Or a domestic violence victim, or relationship violence. They completely, and Trudy could probably speak to this from Dove Center. I'd be terrified to have my name listed somewhere, that someone might find me. It's scary, scary stuff.
Yeah, we had a couple of comments in the chat along that same line. Anna talked, it says, yes, personal trauma and historical trauma from the countries of origin. And similarly, Sarah mentioned fear of the unknown of what happens at the clinic. We had a team create a video for new refugees with different language options that walked through what the first visit would look like and walked through the clinic so they could know what to expect to try and help alleviate that fear. That's awesome. That's a great idea. Definitely something worth considering implementing if that's something that is a possibility. Trudy, it looks like you unmuted.
I was just gonna say, as far as foreign and immigrants, I haven't, and I'm the grants manager, so I don't work one-on-one with our clients. So, but I haven't heard about that, but that doesn't mean it doesn't happen. One thing that I have heard about is individuals from plural families out in Hilldale. We serve that community, and they experience the same situation where they'll need access to services, but they've told us that they're coming from a situation where they've been in controlling relationships, and they think that the Dove Center is set up like it's kind of a communal living situation, and that communal living situation feels too much like the communal living situation that they just escaped from. And so that pressure and those rules, they don't want to be limited by those rules, so they choose not to access the Dove Center. So we've been working with another organization that's closer to their location to, I don't know, see how we can serve them, to just let them know what our services are and see how we can better word our services, better share what we can do for them, and help them understand maybe that we're not jail.
Yeah, and that's a tough one too, because we've got Hilldale and Colorado City, which are kind of right there by each other, but in different states. And so there's some difficulty there with carryover and such.
I did visit Cedar City Intermountain Hospital, and they actually have an FLDS woman on their board so that they can address that health equity issue, because the women were afraid to come, and they realized they had no clue what lens they were coming from. It seems bizarre, but it's working.
Well, I'm glad to hear that. That's great. See, I'm right here in Cedar City and didn't know that at all. So that's really helpful and really, really great. See, it's great that we can bring up these issues that we're seeing, but also bring up some solutions that have worked in other areas. Are there problems you've identified but don't know or don't have an answer to? So I think we can try and implement solutions, and this ties into the last question, but is there anything that's just kind of stumped you?
I know for us, housing has been in every, all demographics in the community. It's hard enough to find housing when you have a job, and it's almost impossible to find housing if you don't have a job and then you want to get something going, even like a basement apartment, whatever it might be. It has been really hard for us to be able to help people find places to stay.
I think one problem we run into is trying not to overreach, especially like in the state area. We don't want to duplicate what other people are doing, but we also want to help. And so I think there's kind of a hesitancy to like jump in, not wanting to like step on toes or groups that they're already working with. And so I'm still relatively new to this position, but I don't really know what the right answer for that is.
Yeah, both of those. Yeah. Oh, Trudy, go ahead.
Can I pose a question maybe to the group, and hopefully this fits into the conversation we're having? I think it does, but as far as barriers, I've been writing a grant for, I'm trying to remember which grant it was, but it's to support, well, as far as housing. So one of our issues was that we were trying to show that my words are not coming to me. I were trying to show that the poverty level here in St. George is what it is. But when I looked on the Census Bureau, the data shows that poverty level is actually decreasing, which I don't think is the case. And then I also found that across the nation, they're showing stats that poverty is decreasing across the nation. Does anybody have anything to back that up or help me know where I can get better data? So that, because when I write grants, if I can't show that poverty is increasing, if I show that poverty is decreasing, that goes against the grant that I'm trying to justify.
So when we went to a meeting that was with the Uinta Basin Governing Association here on housing, during that meeting, we were told that the information that is being given right now is not accurate because of COVID. The stats that they were able to collect isn't actually factual, and they don't know when that is going to be able to be done.
Okay, that really stinks. That's incredible to know. I wonder, Trudy, if Kim C. Gardner would have some information. Are you familiar with them?
No, I'm not.
I'll send you some info.
Okay. The only thing I could logically think of is that here in St. George, we've got a lot of higher income influx into our area. And so I think that's skewing our numbers. If we have more, if we have higher influx of high income, it makes it look like our population of low income and poverty is down, because they're not reporting actual numbers, they're reporting percentage of the population. But then I saw that it applied across nationwide. So that's good information that's skewed by data from the COVID happening.
So a couple of the things that they said was, one, it was because there was a ton of people moving to different areas, and and that they wasn't counting their household as they should have been. And then the other thing was that where everybody was working from home, that there wasn't enough accurate information to be able to give those numbers.
Yeah, that's great info. Thank you for contributing to that conversation. Great to know, and good to know the issues that you're seeing that maybe the answers aren't so easily accessible to, so that we can hopefully address those. If not in this series, then maybe in an upcoming series that we may be able to do. This one's a little bit different. And maybe just something to think on more than to answer now, although you're free to answer if you have thought about this. But what threats to health equity do you envision on the horizon? Because we can address what's here and in the now, but it's also good to be looking ahead and thinking about what issues may arise as things continue. Just for time's sake, we're about done here, which is great. But maybe just some thoughts on how you're handling inequity, how you are addressing it as it comes up in your day-to-day lives. Just really quick while you're thinking on that, a few people in the chat have linked to the Healthy Places Index. And there are links there. That's a great resource. Highly recommend using that if that is something that will be helpful to you. We had a chance to get some training on that not long ago with our organization, and it was really good to see that. I think a lot has been posed that's really good. We've seen some good conversations happen here, and this is what we hope to have happen for the rest of the series. We hope to invite people in that are, experts in their field that we can pose questions to and have discussions with. But this gives us a good baseline of things that we can look forward to going forward, how we can shape the content of this series, partners we may want to involve. So I would just, as we sort of close out this hour, I hope that you will reach out to people in your network that you think this may be useful to. We did record today's session and we'll be doing that for all of them. So even if they're unable to attend all 6 sessions, and this goes for you as well, if you're able to attend some but not all of them, there will be recordings that you can access on RHAU.org, the Project Echo page, and I will send, or I'll put it in the meeting notes or something, or I'll send you all an email with that page so that you can access it. But feel free to continue to invite people to this series and to see how we can all work together on inequity and addressing health equity in Utah. Because we know that this is something that's important if we want to continue to better the health system and all the things that we are working with. We know that addressing equity and inequity is vital to that. So thank you all for joining today. Feel free to email me, call me, text me. I think you all have my phone number with things. And then typically in an echo session, there will be a post survey. So we did the pre-survey. We've decided to do that since this series is sort of one cohesive unit. We've decided to do that at the end of the series instead of the end of each session, just so we can sort of look at it holistically. So you're welcome to log off. Thanks for joining us, especially those of you who took, your lunch hour to be here. But we appreciate you all coming on and joining us, and we're excited for the rest of the series. I think this is going to be a really great opportunity for us to look for those solutions.
Thanks, everybody.